Good evening. My name is Eric Isaacs. I'm president of the Carnegie Institution for Science. And it's a real pleasure tonight for me to introduce Martine Rothblatt. As the chairman and CEO of United Therapeutics, Martine Rothblatt revels in her company's unofficial mantra, identify the corridors of indifference and run like hell down them. Throughout her career, or more properly, her multiple careers, Dr. Rothblatt has been running like hell down the corridors of indifference and leaping over every barrier placed in her path. As a lawyer, an entrepreneur, a medical ethicist, and most recently, the head of a groundbreaking biotechnology company, she has demonstrated an extraordinary ability to see opportunities that others do not, combined with a willingness to jump in where others have held back or turned away. Her career in technology got its start when she was still a teenager. She took some time away from college to travel to the Seychelles Islands seeking a tropical paradise. Instead, she found her calling. She was invited to tour the U.S. Air Force Space Tracking Station there, which was part of a worldwide network set up to help NASA track satellites. And when she walked in, she saw this gleaming facility and felt as though she had stepped into the future, which she had. After a few years, this transformative experience inspired her to return to college at UCLA, where she earned a BA in communications, a law degree, and an MBA. After a few years at the prominent law firm, Dr. Rothblatt quit to launch GeoStar, which used a satellite-based positioning and communication system for car navigation. And then in 1990, Dr. Rothblatt co-founded Sirius Satellite Radio, which brought an incredible array of programming to car radios, as many of you have probably used it yourselves, and created a new business model that has disrupted an entire industry. Then her life took a sudden change when her young daughter was diagnosed with a rare threatening illness, and doctors could offer no cure. So Dr. Rothblatt jumped into action. She founded United Therapeutics, a pharmaceutical company focused on developing new, effective, patient-friendly treatments to help her daughter and the many other patients like her around the world. She also turned her attention and intelligence to knotty issues of gender identity, publishing several books, and ultimately pursuing a PhD in medical ethics. Now Dr. Rothblatt has identified a new challenge, the deadly scarcity of viable transplant organs. In this work, Dr. Rothblatt makes an important distinction between moonshots and earthshots. For her, a moonshot is an extraordinary, far-reaching goal that would require years of massive effort to achieve. In this realm, the moonshot would be to have an unlimited supply of transplantable organs. An earthshot, by contrast, is an ambitious but more achievable objective that takes an important step toward our ultimate goal. So Dr. Rothblatt is focusing her company's current efforts on xenotransplantation, which involves transplanting animal tissue or organs into humans with new technologies that will enable doctors to save more organs for transplant. These are enormously important research questions, and finding solutions could save hundreds of thousands of lives. When Martine Rothblatt was honored with the UCLA Medal last year, the dean of the School of Management called her, quote, the most interesting person you will ever meet. Please join me in welcoming this visionary leader, Martine Rothblatt.
Thank you very much for that very, very generous and kind introduction. I'm most honored to be invited to speak here at the Carnegie Capital Science Lecture Series. So, as was indicated, I'd like to give a personal perspective on the topic of turning moonshots into earthshots. And maybe we can start with a video in this year of the 50th anniversary of the landing on the moon by Apollo 11 to recall some of those heady moments.
I believe that this nation should commit itself to achieving the goal before this decade is out of landing a man on the moon and returning him safely to the Earth.
That's a picture of a laboratory and medical facility that we have in Silver Spring, Maryland. And about 8 years ago, 2011, I inaugurated this building with a challenge to ourselves that before the end of this decade, the 20-teens, that we would transplant an end-stage lung disease patient with a manufactured organ and return them safely back to health. It seemed like a moonshot. It was inspired by a moonshot and inspired by JFK's speech, which is iconic for a moonshot. The United States accomplished JFK's challenge during the 1960s, but not as originally envisioned by scientists such as Wernher von Braun in 1960 and 61 and even 62. Not with a single-stage nuclear rocket that would blast off from the Earth, go direct to the moon, land on the moon, and return back to Earth. Because in fact, while that would have been an awesome means of propulsion, there was no practical way, as things got underway, to develop an atomic-powered rocket during the decade of the 1960s. And ultimately, as we know, we did successfully go to the moon during that decade, but we did it through a very novel architecture involving rendezvous and docking, and a very risky step involving blasting off from the moon with a tiny module that, in fact, if it did not successfully rendezvous in lunar orbit, would have had no possible way to get back to Earth. In our case at United Therapeutics, I had originally envisioned in 2011 that we would be able to manufacture an organ from scratch. In a moment, I'll show you a video of what was contemplated and still is contemplated, but basically by kind of 3D printing an entire lung. And as we moved into 2011 and 2012 and 2013, that turned out to be a very awesome way to produce organs, but there was no way that that goal would be accomplished before the end of this decade. And so, again, inspired by Apollo, and Gemini, and the entire Moonshot program, we pivoted to a technology involving using dead lungs that had been donated by people who met an untimely death, but whose lungs were not usable for transplantation, generally because after the kidneys had been removed and the liver had been removed, the lungs had filled with so much fluid and mucus that they were useless, and nobody in their right mind would put them into an end-stage lung disease patient. So they are thrown into the bio-waste. Instead, we developed a technology to restore those dead lungs, to bring them back to life, flying them back and forth across the country to this center that you saw the picture of, and ultimately onto patients, and have now successfully saved the lives of many dozens of patients in this decade with those otherwise useless disposable lungs. So we did manufacture lungs in this decade and return patients safely back to health. So not to be overly semantic and didactic with everybody, but since a lot of these terms are vague anyway, I thought I would start off with a couple of definitions. I look at a moonshot as something that conventional wisdom says takes generations but is done in a decade. And certainly the conventional wisdom was that the United States would not successfully land a man on the moon and return them safely back to Earth during the 1960s. Kennedy went out on a limb with that goal, but remember, at the time he said that, we had only just a couple months before sent the first person into orbit around the Earth, and just a couple orbits at that. And most rockets before that, during the 3-4 years before that, exploded on takeoff. So it was something that most people thought could be accomplished in a generation or generations. Sooner or later, we'll get there. But we were in a race with the Soviets. And the question was asked by Kennedy, what can we do that will beat the Soviets and demonstrate clearly U.S. technological leadership? One idea was we can build a space station. And von Braun and other advisors told Johnson, who was really Kennedy's point man on the space program, Russians will get a space station up there before we will. And some people said, we can land something on the moon. The Russians will land something on the moon. We could orbit the moon. The Russians, we might beat them to an orbit, but we might not. We can land a man on the moon. Now, nothing disparaging here to the Soviets, but the chatter in Washington is they'll land a man on the moon, but they won't be able to bring him back. And the U.S., that's not our way. So we can land a man on the moon and safely bring him back to Earth. Kennedy said, that's the American challenge. That's the one we'll do. Like many great futurists, he was wise to pick a time frame that actually went beyond his 8 years in office. Unfortunately, as we all know, he did not live to see this personally, but we all have benefited ever since, and I personally have benefited growing up, watching this, and then being inspired to save so many lives at United Therapeutics through a similar challenge. So moonshot, conventional wisdom says it takes generations, but it's done in a decade. Now, a kind of new word, somebody else probably made up this word before I did. I feel it's a neologism. I consider an earthshot to be a moonshot that's done sustainably, helping people on Earth. Now, what I mean is by sustainably is not kind of like a green energy sustainability, but I mean an ongoing self-supporting ecosystem. And what space historians are biting about in their critique of the Apollo program is that the U.S. invested these enormous resources creating the Saturn V rocket and a whole system to land people on the moon, and as we know, we pretty much just threw it all away in the early 1970s. And here we are 50 years later, and we've got kids and grandkids looking us in the face and say, let me get this right. You guys figured out how to go to the moon, and then you didn't go back there ever again? I mean, it is embarrassing, right? I feel embarrassed, you know. So an earthshot, I think, is a moonshot done sustainably, helping people on Earth. And that's what I've been inspired with, and our company has been inspired with for manufacturing organs. We could and have, through superhuman effort, manufactured an organ and saved 1 or 2 people. Some of you may remember the saga of baby Faye, a young infant in the 1980s whose life was briefly saved with a baboon heart. It was not done sustainably. It is not a sustainable model to transplant primate organs, of which primates are limited in number, even though baboons are more numerous than great apes. But it's not sustainable to address the hundreds of thousands of people who need organs with primate organs. So it wasn't sustainable. But what I'm really fixated on are moonshots that could be done sustainably as part of an ongoing ecosystem that continues to benefit people all the time. And that's what we do with our organ manufacturing program, as I'll show you during the course of this lecture. And that's what I hope we're doing in a couple of different ways. So during the course of this lecture, I'm going to go through 3 different examples of how I believe United Therapeutics has turned or is turning moonshots into earthshots. So the first opportunity that we had to turn a moonshot into an earthshot was when our daughter, Genesis, was diagnosed with a rare fatal disease called primary pulmonary hypertension. At the time, I was the chairman and CEO of SiriusXM, and I had, my newfound soulmate, Alan, wherever he is, astronomer, astrobiologist, Alan, there you are, thank you. I had last taken biology in 9th grade. Alan shared that with me before our talk. So I think you could say, you know, how can this satellite radio expert save their daughter from a rare disease? It sounds like something that might take generations to figure out a cure for a rare disease. We have 7,000 rare diseases recognized by the Food and Drug Administration, and only a handful have medicines approved to treat them. So I would say in general, it is a moonshot to cure a rare disease. And in general, it's something that would take generations. The disease that our daughter was afflicted with had several characteristics that made it a particularly onerous moonshot. At the time she was diagnosed, there were only 2,000 patients in the United States. In general, there's no genetic basis for this rare disease. It likely occurs because of a genetic predisposition, but there are changes during the individual's life, somatic mutations that occur, that end up cascading them into this terrible disease, which is characterized by a constriction of blood flow just between the heart and the lungs. The average patient was dead in 3 years. The average age was 30 years old, but there could be young kids like our daughter and seniors as well. The typical patient was a woman, usually several years after childbirth, but a third of the patients are men. There were only 2,000 patients because as the natural incidence of this disease occurred, the prevalence could never grow larger than 2,000 because the patients died. There were only 40 doctors in the whole US who even saw any patients with pulmonary hypertension. And when I first visited the first doctors and I said, what can I do to help? They said, get somebody interested in this disease because nobody wants to be involved with it. It's extremely depressing. All your patients always die. Another aspect of this disease that made it a particularly onerous and long shot, moonshot, was the disease didn't affect a part of the body that was very easy to reach. It affects only the most distal portions of the pulmonary arteries. From the heart, the freshly oxygenated blood flows out of the left side of the heart. It goes throughout your whole body, and then it pours into the right half of your heart. And the right half of your heart then pumps that blood into the lungs. It does that through a pulmonary artery. Arteries is where the blood exits from the heart. So it exits from the heart, this pulmonary artery. It splits to the left and the right side, and it splits and it splits and it splits. It splits some 18 times. And as many of you know who have ever just kind of doubled 2, 2, 4, 8, it grows to be a very large number, and after 18, it's in the many millions. So this disease affects the tiny back end portions of millions of tiny arteries. When I first was working on this, people would say to me, well, why couldn't you just stent the artery? I think you could see that's completely impossible in this case. So it was a very, very difficult type of disease to come up with a treatment for. If you could, for example, find a way to open up these pulmonary arterioles, arteriole just meaning like a very teeny tiny artery, most of these are just about 20, 30, 40 microns in diameter. if you say open up all the blood vessels, the individual will collapse face down because there are systemic pressures. The pressures that you would check with a sphygmomanometer, one of these devices that you buy at the drugstore to check your blood pressure, is perfectly normal. The only place where they have super high pressures is in this tiny back end portion of the lungs. And by the way, if you have a problem with essential hypertension, as probably 1 out of every 3 people in this room or in the country have, the blood pressure, they tell you if it's 180 over, say, 100, that's bad. Well, that's about 50% higher on the systolic side, about 20% higher on the diastolic side. The normal pulmonary artery pressure is 15 millimeters of mercury. The patients with this disease have pulmonary artery pressures of 75, even 100 millimeters of mercury. So 5 times, 6 times the normal pressure, way beyond anything that most of us with systemic or essential hypertension would experience. So as a result, when the right heart tries to pump this blood to the air sacs, the alveoli, to get some fresh oxygen, it can't get through. The pressure is so high there that the tiny arterioles can barely let any blood through. And the blood backs up in the right side of the heart. The right side of the heart tries harder and harder to pump, and then finally it just collapses. And that's what happens within 3 years. So to go along and say, I'm going to cure this disease before my daughter succumbs to it, off the top hand, that sounds like a moonshot. It's like it's going to take some generations. Another thing that made this a moonshot is that there was absolutely no pharmaceutical industry interest. I promise you that the first thought that came into my mind running SiriusXM was not, I'm going to start a pharmaceutical company and save my daughter. I didn't even know what I would be doing in that type of a field. The first thought that came to my mind is I've got to get a pharmaceutical industry interested in treating this disease, just like the first thought that comes into my mind with satellite communications companies is I have to get a car maker interested in putting SiriusXM radios in their car. These sorts of ideas have to get somebody in the business interested. I visited all the big pharmaceutical companies. None of them had any interest. The reason they had no interest is they said, how can we make any money off of a disease that only affects 2,000 people? At this point in time, there was no conception of how to do that. When I said to them that I can raise money and donate money to do this, their response was, we have a business model which is based on we need to earn at least $1 billion a year, and which is the typical pharmaceutical industry business model. And it's not because they're bad or anything like that. It's because, as I'm sure you've read in the Post or the Times, wherever, it takes about $1 billion to develop a new medicine. And it takes about 10 years or even longer. So, and the risks are high that any given one won't come to fruition. So in fact, I think it's entirely reasonable for the pharmaceutical industry to believe that they need to have a market of at least $1 billion to cover all the costs and the risks that go into creating a new medicine. So they were not interested. After a lot of research and self-education, I found a molecule that was selective in addressing only the pulmonary arteries. It was selective in widening only the pulmonary arteries and not the rest of the arteries in the body. And, to a person who's in a dark forest, the smallest light looks like the greatest hope. And that's how I felt. However, the ownership of that molecule rested at Glaxo Wellcome. So in order for me to go forward in any way, in order to turn this moonshot that would take generations into an Earthshot that could be accomplished in under a decade and hopefully in time to save our daughter, I would need to get this intellectual property out of Glaxo Wellcome. And so I visited them once, twice, 3 times. Every time they had objections why they could not license this intellectual property to me. First, they said, you don't know anything about medicine. It would be unethical for us to license you this intellectual property. So I found some people who did know a thing or two about it, including the great late Sir John Vane, who had won a Nobel Prize for the biochemistry underlying this molecule, as well as COX-2 inhibitors such as Celebrex and other very useful drugs for inflammatory conditions. And then they said to me, well, it's good that you have this team of people, but we really don't license out our drugs to individuals or foundations. You would need to, form a pharmaceutical company and have some assets, or else this would just be a mockery and an inappropriate business thing for us to do. So I did all of that, created United Therapeutics, hired in some more drug development experts who knew something about this area. Finally, it came down to the negotiations. And they said, Martine, we really sympathize with you. We're sorry about your daughter. But we have to tell you, this is kind of a fool's errand. Because while we do have intellectual property on this molecule only lasts a few minutes in the body. And therefore, it would have to be delivered 24 hours a day continuously. You would have to hook up your daughter to an IV pump, like a tree on some wheels. And by the way, in addition to that, we really don't know how to synthesize this molecule in more than gram quantities, which would be too small to be useful. So we have no way to make it commercially. We have no way to deliver it practically. This is a fool's errand. And I said, just give me a price. And I think that I had worn their resistance down. So finally they said, look, we have absolutely no, we're an ethical pharmaceutical company. We don't like to take people's money on false pretenses. If you give us $25,000, we'll give you the rights to this molecule. And before the end of the day, lawyers are going to be in the mix somewhere. And the lawyer said, and 10% of any money that you might make in the future. So that was our moment of turning a moonshot into an Earthshot. So the first obstacle that had to be overcome was we had to create new pulmonary selective biochemistry. As I mentioned, even Glaxo, which at that time was in partnership with one of the greatest chemical companies in the country, no longer an independent company, but some of you may remember the name the Upjohn Company. Neither of those two could figure out how to synthesize this molecule into medicinal quantities. We visited chemistry companies and chemistry departments across the country. And finally, at the University of Illinois' Department of Chemistry, we met a man, Dr. Robert Moriarty, who was the chairman of the chemistry department at the University of Illinois. And Dr. Moriarty said, I can envision a way to create this chemistry. I'll need a couple $100,000 of funding to try some things out, but if you can fund me with that amount, I'll try to create something that all the great pharmaceutical companies and chemistry companies couldn't figure out. And he was successful. And he is named as on the patent for the synthesis of this pulmonary selective molecule. He's still alive today, and if you come and visit our building in Silver Spring, you'll see his image engraved in granite there, because were it not for the inventiveness of Dr. Moriarty, we would not have been able to save all the people that we save today. But remember, there was, aside from the molecule, the innate chemistry of this molecule was that it only lasted a few minutes. And you can't take a pill every few minutes, so how are you going to deliver something continuously? Around the same time, another great inventor, Al Mann from California, whose daughter suffered from diabetes and was tired of seeing his daughter go through all of the self-injections, came up with a continuous infusion pump for insulin, which was ultimately approved by the FDA. And we had the idea, if you can have a continuous infusion pump, and I should mention this was not like a pump that you had on a tree, on a drug delivery tree with wheels in a hospital. This was the size of a deck of cards. And you could wear it on your belt, or you could slip it in a pocket inside a vest or a bra or a jacket. And as far as the world knew, you weren't on any drug at all. You did not feel ostracized in any way as a patient. So we went out to Al Mann's company. It was called MiniMed. Today it's a part of Medtronic, a great medical device company up in Minnesota. And we said to Dr. Mann, we would like to repurpose your insulin pump to deliver our molecule, our pulmonary selective molecule. Well, there were a lot of reasons in the drug business that you don't want to do things like that. Because if it turned out that repurposing that pump for our molecule ended up killing some of the patients that we had on that molecule, who would get the bad name right away? I mean, it would be the pump that got the bad name, and people would be afraid to use the pump. And in the general, sounds like the mic went off. I'll just use this one. In the pharmaceutical industry, companies are very cautious and careful about using approved things for something unapproved that may hurt the name of the approved thing or even lead the FDA to pull it off the market, which they've done before. But we were successful in persuading Al Mann to allow us to re-engineer this MiniMed continuous subcutaneous insulin delivery pump into delivering treprostinil, which is the name of our pulmonary selective molecule, 24 hours a day, 7 days a week, 365 days a year. And so now, you see, we overcame the chemistry problem. Before that, we overcame the institutional problem. And now finally, we overcame the drug delivery problem. I wish I could tell you that those were all the problems. But you do not create moonshots and you do not create earthshots like at the snap of a hand or pulling a rabbit out of a hat. This stuff takes persistence. This stuff takes just, just almost an insane level of stick-to-itiveness. So after figuring out all of this, we did a clinical trial, which is what you have to do to get the FDA's approval. And we were a startup company. It was a company run by a kind of a satellite slinger. Didn't know too much about medicine. Last biology course was in 9th grade. And so we did not design the clinical trial as well as it could have been designed. Now, to show you how close we came, for the FDA to approve a medicine, generally speaking, you have to have 2 clinical trials, each of which shows that the medicine is better than a placebo. So that's what's called a randomized placebo-controlled study with a statistical certainty such that the odds of the result being a fluke are less than 5%. Which is called in the industry a p-value of less than 0.05. So you got to prove it twice that's less than 0.05, because the FDA doesn't want to approve medicines that are not effective, aren't proven to treat a condition, and then maybe people would use that phony medicine instead of taking a real medicine, and that wouldn't be a good thing. When we did our clinical trials, we did 2 clinical trials. We figured out how to do that. One of them came in at 0.055. I mean, between friends, it's like, of course the drug worked. The other one came in at 0.062. Between friends, of course the drug worked. But to the FDA, one of their reddest of lines, brightest of lines, is this 0.05 line. And there are more drugs than I've got fingers and toes to count that have been canceled by the FDA because they missed this 0.05 threshold. Oh my God. After all these visits to Glaxo, after hiring all of these people, after figuring out new chemistry that never existed in nature before, after creating a re-engineering of something that had never been done before, after conducting a clinical trial at dozens of hospitals with hundreds of patients, to see your life just like crumble before you. And all the meanwhile, our daughter goes from spending weeks in the intensive care and lips cyanotic and blue from lack of oxygen, her right heart 2.5 times its normal size, situation getting worse and worse. When I was at in the satellite communications business, and we would bring new technologies to the FCC, they were often skeptical because every new technology requires scarce radio frequencies. And when we brought the idea of satellite radio to the FCC, and we said that we needed these radio frequencies right here in the middle of some microwave radio band, the very valuable band of frequencies. They were used by the television industry for electronic news gathering. And 20 years ago, that industry was a lot more powerful than it is today. They weren't going to give us the frequencies. So what we did is we went out to the grassroots, to small organizations throughout the country, to pilots, to everybody that might be able to benefit from having information transmitted everywhere at the same time. And we got dozens of organizations to write letters to the FCC saying it is in the public interest for you to go ahead and allocate these frequencies to this unproven technology, because for the first time people in rural areas could get information that they might not be able to get if, say, a hurricane or a tornado came through and knocked down all of the broadcasting stations. Or pilots flying from 2 points in the middle of the country could get information on what the weather is at their next destination, and maybe it's not a safe place to land and they should divert the plane to another location. So it was because of this public interest outcry that the FCC ended up granting us the frequencies for Sirius XM. Well, fortunately, we were able to avail ourselves of that force of society with regard to our medicine for pulmonary hypertension. And the FDA called a public meeting to decide whether or not to approve our medicine despite having missed their red line twice. Now, we did some statistical manipulation, and we showed that if you combine both of the studies into one big study, that it was very statistically powerful. But the FDA is not really a big fan of like changing the rules after the game. And however, we were very blessed by the pre-existence of a wonderful organization called the Pulmonary Hypertension Association, made up of patients, their families, their friends, allies, who were there to help the patients with pulmonary hypertension. One of the founders of that organization, Bonnie Dukehart, a wonderful, wonderful person who, despite being severely debilitated with pulmonary hypertension herself, nevertheless, more or less brought up this grassroots organization on her kitchen table. And I wish Bonnie was with us today, and I wish that she had really lived long enough to see our medicines end up getting approved and in use. But through her pulmonary hypertension organization, we had patients come and testify to the FDA, and they said, I could not walk up the 2 stairs to my front door before I was on the United Therapeutics medicine, and now I can. I could not walk around the aisles of the store before I had my medicine from United Therapeutics, and now I can. And after hearing this testimony from the patients themselves, one of the top biostatisticians at the FDA, Dr. Bob Temple, came and said, I would like to stand up in front of all of the top chiefs here at the FDA. Now, he had rarely done that. He is a biostatistician. He's the boss of hundreds of people at the FDA. And he got up on the stage right over there in Rockville at the FDA's headquarters, and he said, I have no doubt that this medicine works, and even though I am a biostatistician, I'm a biostatistician because I believe that we should use statistics to help us find truth, but we should not be a slave to the numbers. We should be a slave to the truth. And thanks to Bob Temple, the FDA panel that was there at the meeting voted by majority to approve our medicine. Now, as you recall, one of the many challenges in turning this moonshot into an earthshot was no pharmaceutical companies were interested in it because they said, how can we make any money off 2,000 patients? So we too had that problem. We had to raise money to pay for all of the drug development. So we came up with just a business model that we said, why don't we consider an orphan disease no different than any other disease? Yes, it afflicts fewer people, but that makes it no less important. For example, if our country was invaded just on one of the islands of Hawaii, but not the whole continental United States, we shouldn't spare in our effort to defend that one of the 5 islands of Hawaii. It's still part of the United States. And because mankind's natural enemy, a disease, afflicts a fewer number of people, an orphan disease, that makes it no less important than a disease like cancer or heart disease that affects all of us. So we talked to the insurance companies and we said, would you have any objection if we price this medicine such that the total payment burden for this medicine would be about the amount of money that's needed by a pharmaceutical company to recover their investment and continue improving the medicine to make it better and better. And they said, well, that would be about $1 billion a year. I mean, everybody knows that number. And so we said, yes, although there's only 2,000 patients right now, we believe there will be more and more. And we would need to price this medicine at about $90,000 a patient per year. So they ran the numbers and they said, 90,000 times 1,000 patients, that's $90 million, times 2,000 patients, that's $180 million. Right now we're paying $1 trillion for drugs. Okay, it's 1/10 of 1%. We wouldn't have any problem with that. So that's where we set the price for this medicine. Suddenly, the last burden that this project could not economically go forward in a sustainable manner. Remember, our Earthshot is something that's sustainable. A very wealthy person could have conceivably done all of this to save 1, 2, or a handful of people, but then it would just peter out. You have to make it a real business to make it sustainable. And what's critical is to never stop improving the solution. When I came home and I said to our daughter, I think we found a way to save your life from pulmonary hypertension, she said, oh, great, how's that? I said, well, you just have to wear this pump, attached to your body with a catheter and stuck into your skin. And, her eyes started rolling. She said, my friends at school with asthma, they just have this little thing in their pocket that they breathe. Why couldn't have you invented that? The point is that you have to keep improving the solution. And today, in 2019, that little medicine that Glaxo Wellcome thought was not worth $25,000, that nobody else thought was worth anything at all, today brings in revenues for United Therapeutics of $1.5 billion a year. Here's kind of why you could see that's the case. This chart is a KAPLAN-MEIER curve that was published by the National Institute of Health when they conducted a registry of the pulmonary hypertension patients. And here you see this FC3, so that stands for Functional Class 3. And the New York Heart Association has developed a categorization of how bad off people are with heart disease. And while I mentioned it affects the lungs, but people ultimately die from the right heart failure. Functional Class 1 are people who go about their normal activities with ease. Functional Class 2 are people who have symptoms and such as breathlessness at a normal level of activity. People in Functional Class 3 have serious symptoms with less than normal activity. Just walking up a few stairs makes them winded, breathless. They may not even be able to do it. And people with Functional Class 4 are essentially bedridden. So you can see here that this is a chart showing the passage of these Functional Class 3 patients from the time of their diagnosis, which is over here, until the time of their death. And at 18 months, half of the patients have died. Like I told you at the beginning, 3 years. For most people, the median survival is 18 months. If you presented originally as a Functional Class 4 patient, which many, many did, because no matter how smart a doctor you are, to figure out that a person's problem is lying at the end of 15, 16, 17 branches of distal pulmonary arteries is not easy. And this is what's called a diagnosis of exclusion. Thank you. You have to exclude like a gazillion other things before, okay, I guess it's pulmonary hypertension. So it's a very, very grim situation. The reason why this product is so successful today, and the reason why it's been able to save so many lives, is because here is the Kaplan-Meier curve for United Therapeutics product. So even after this period of time, 30 months, they're it doesn't work perfectly for everybody, and some people unfortunately still die, but it doesn't even get to the 50% mortality level. So clearly, you're better off with this medicine. The insurance companies and Glaxo and everybody who thought that this was a moonshot and not an earthshot, they kind of locked and loaded on that 2,000 patients. Okay, this person's got something for 2,000 patients. It costs a lot of money for that medicine, but 180 million is something we can handle. However, as you saw from the previous chart, if you have something that keeps people alive and you have a constant incidence of people developing this disease, then obviously what happens is the prevalence of the disease grows larger and larger. So said in a somewhat, I think, a very charitable way, but some people think this doesn't sound that good, one of the main things that United Therapeutics has made is an awful lot of pulmonary hypertension. But the good news is that these patients are overwhelmingly living active, happy lives, and we have taken that those revenues that we received, and we continually plow them into better and better medicine. So that first one was approved by the FDA here, and that was the Earthshot, because that medicine generated enough revenue to create a sustainable revenue stream that allowed us to get more medicines approved in 2008 and even more medicines approved in 2014. And we had another approval last year. And so I believe that the numbers of pulmonary hypertension patients are going to continue to grow and grow. And in fact, my prediction would be that sometime in the coming decades, pulmonary hypertension itself will no longer be considered an orphan disease because so many people will be able to live full lives with it. Now, the best news of all is that the person who was responsible for all of this activity, who is singularly responsible for the fact that there can be tens of thousands of lives of people. Here are the numbers of patients over there, tens of thousands of lives saved, is our daughter Genesis, who is a very active, happy, 34-year-old person today. And she got that wonderful charisma that you can sense there from my wonderful partner of 37 years, Bina, who's sitting right here in the front row with me. All right. Do I have time for another moonshot to earthshot? Okay. Chapter 2. Now, as you saw from the chart, it's a challenging disease, and we have not cured it because people have to take these medicines for their entire life. And because of some individuals' unique biochemistry, the medicines stop working. And I have had the pleasure of meeting many brave pulmonary hypertension patients who ultimately were just overwhelmed by the progression of their disease. Interestingly, nobody has ever developed a reoccurrence of pulmonary hypertension after getting a lung transplant. But there are only about 2,000 lung transplants each year, and there are about 250,000 people who die each year of end-stage lung disease. So in general, your odds of getting a lung transplant are small if you have a end-stage lung disease condition. And because there are so many much more prevalent end-stage lung diseases than pulmonary hypertension, such as COPD, emphysema, pulmonary fibrosis, only about 10%, so about maybe 200 of the lung transplants each year go to patients with pulmonary hypertension. So we ask ourselves, is there a way that we can help all of the patients with pulmonary hypertension, also the patients with pulmonary fibrosis, cystic fibrosis, COPD, even lung cancer, by manufacturing organs the way companies manufacture machines? Well, right off the bat, I would say it's a moonshot. How can you manufacture organs? Nobody's ever done that. So we created, as I mentioned at the beginning of the talk, a machine which is called an ex vivo machine. It just means an outside of the body machine. Its full formal name is a ex vivo lung perfusion machine. And for short, we call it EVLP, ex vivo lung perfusion machine. That could take these thrown away lungs, discarded after being donated, and bring them back to life and use them to increase tremendously the supply of transplantable organs.
3D bioprinters at United Therapeutics DECA Organ Manufacturing Center in Manchester, New Hampshire, print the inert collagen scaffold of a lung from its larger proximal vessels and bronchi to its millions of distal arterioles. End-stage organ disease patients give up a few cells in a biopsy, which will be transformed into inducible pluripotent stem cells, all matching the patient's DNA to avoid any need for immunosuppressants. It was just in the past decade that science has learned how to turn differentiated human cells back into stem cells. Thereafter, the newly made stem cells can be redifferentiated back into a wide variety of different types of cells. In our manufacturing laboratories, we will redifferentiate newly made stem cells from a patient into endothelial, epithelial, muscle, and connective tissue cells that match the patient's DNA. After expanding the numbers of these differentiated cells into the tens of billions needed to cellularize each organ, we stream them into the previously bioprinted scaffold. The entire process of cell expansion and recellularization via streaming takes about 2 to 3 months per organ. At the end of the process, there is a newly manufactured, personalized organ that matches the DNA of the intended patient. Once removed from its bioreactor, the organ needs to be transplanted within hours. A TransMedics cart will be loaded onto an EHang manufactured organ transport helicopter, or MOTH, for delivery to the surgeon's operating room.
So that's the moonshot. That's what people said is a moonshot. And did you see in the video the TransMedics cart that was rolled? That's what's called an ex vivo lung perfusion machine. During the 20-teens, it became clear that we would not be able to achieve that moonshot in the 20-teens. So we said, well, we've got the cart. We've got this ex vivo lung perfusion cart. Why don't we use that in the 20-teens to save organs that are otherwise being thrown away, and then use the revenue and the income from that process to fund the entire 3D printed lung that you saw in the video. It's actually very similar to the concept of what we did with our medicine, where why don't we use the difficult catheter-delivered 24-hour-a-day ambulatory pump to fund our efforts on developing the inhaled and the oral forms of our medicine that you saw were approved in subsequent years and finally made our daughter happy. So 50% of Americans are organ donors, but less than 1% die in a way, which is brain death, that the organs are used. So while it's very, very important for everybody to be an organ donor, you can see from the numbers that even if 100% of people were organ donors, because of the way that most people die, you would never be able to have enough lungs to satisfy the needs of even the people with pulmonary hypertension, not to mention all the other end-stage lung diseases. What's especially agonizing, I guess, or angst-creating, is that of that 1%, that precious 1% that were able to use their organs to save other people's lives, 80% of the lungs are thrown away. And so that's why we said, hey, while we're developing this moonshot, we've got an immediate Earthshot we can do right now. We could take that 80% of lungs that are otherwise being thrown away, and we can salvage them on this cart and take them and clean out all the muck, all the mucus, suture up some minor tears that might have occurred from an accident, and make these lungs available for transplant today. So we built, we had to, again, it was like any other Earthshot. You have to overcome many obstacles. One obstacle is that people die all over the country. Their organs are needed in all different places of the country. How are you going to get those organs, those lungs, that were going to be thrown away and fix them? I mean, so what we decided to do was we would build a special purpose lung treatment center. And we would fly the lungs from wherever the donors died in different hospitals around the country. If they were the lungs that were going to be thrown away, we would fly them to our center in Silver Spring, Maryland, do our best to restore them, or what we call manufacture them, take something that's dead and bring it back to life, and then fly it again from our center to the hospital. Right away, people said, you can't do that. We all know that once you take an organ out of a body, it's only good for, 6, 8, 10, 12 hours, depending on whether it's a kidney, liver, heart, or lung. And by the time you fly this from, Sioux City to Silver Spring, you put this thing, you work on this thing for hours, and then you fly it out to Jacksonville or somewhere, it's going to be 24 hours. For 30 years, we have not been able to successfully transplant lungs that are outside of a body for more than about 10 hours. Nobody realized that once you take the lung and you put it in this ex vivo chamber, and you perfuse it with nutrients, and you treat it like a little tiny patient, that in fact you reset the clock. You get to reset the clock. You get a fresh 6, 8, 10, 12 hours. So anyway, we discovered that. I think it's absolutely awesome. And we also had to train a whole new career type of technicians that are lung doctors. All these people do, these technicians do, is their patients are lungs, and they are experts in working on the lungs. And while they're working, their work is monitored by the transplant surgeon anywhere in the country. Well, how could we do that? We had to create a high-resolution video network, hooking up cameras to bronchoscopes and x-ray machines, so that while we're working on the lung, the transplant surgeon could say, well, I want to look down the left bronchial tube. I want to look on the right, branch it here. And we could show them in real time on their iPad or iPhone or computer desktop, wherever they are, to their satisfaction that the lungs are clean. Because, of course, the transplant surgeon, they've got a end-stage lung patient in their intensive care ward, and they don't want to put anything in that patient that's not going to hopefully go the distance. We created this nationwide biologistics network. So all these different steps, every step along the way, setback, problem, find a way around it. Setback, problem, find a way around it. Let me show you a little video of just how beautifully this works.
Through our lung service model, United Therapeutics currently receives lungs from transplant centers east of the Mississippi River. Our LB1 facility in Silver Spring, Maryland, is the first full-service ex vivo lung perfusion center in the U.S., housing 6 EVLP procedure rooms. Once the lungs arrive at our facility, our CMX system automatically sends a notification to the participating centers, including the OPO, the transplant center, the LB1 clinical staff, and the medical advisory team. The UNOS number and blood type are verified in CMX, and a back table evaluation commences noting organ condition. Perfusion takes place over a 3 to 6 hour period, during which the donated lungs are placed into a sterile plastic dome and attached to a ventilator, pump, and filters. The lungs are maintained at normal body temperature and treated with a bloodless solution that contains nutrients, proteins, and oxygen. Throughout this process, ongoing CMX documentation and assessment steps take place. These include bronchoscopy, X-rays, and blood gas analysis. During this period, our IT specialists facilitate visual and data communication with the transplant centers. Through our EVLP process, we are working to reduce the devastating effects of end-stage lung disease.
So it's actually happening, and here are, literally hundreds and hundreds of patients who would otherwise die. Their lives are saved with these lungs. We keep these counters going in Silver Spring, Maryland. You see the gong in the corner. Every time we save another life, we bang the gong. And it's just a real remarkable program. I had the great pleasure on September 21st of last year. We inaugurated a building, which I'll show you in a moment. But this wonderful lady, Heather Leverington, she was a collegiate women's sports coach. Unfortunately, she developed an especially aggressive form of pulmonary hypertension. She was not going to be able to be treated with drugs to keep her alive long enough to even get to a regular lung. And she accepted the risk of taking our manufactured lungs. Her physician agreed with it. She received 2 of our manufactured lungs at the end of 2017, and in the middle of 2018 was the U.S. Transplant Games. She did so well, she won a gold medal in the shot put at the U.S. Transplant Games. In 2011, there's a video, but I'm going to skip it in the interest of time. I wanted to share with you one last example of a moonshot to Earthshot. We've asked ourselves the question at United Therapeutics, can we build the world's largest zero-carbon footprint building on a modest urban plot in downtown Silver Spring, Maryland? It had never been done before. The zero-carbon footprint buildings that had been built had either been done in rural areas or in places like La Jolla. We would have to, in order to do it, it turned out we would have to change laws, drill 500-foot wells to use the earth as a thermal battery, coat the building with a megawatt of solar panels, and create a brand new automation system that had a level of intelligence that had never been built into any building before, so that it could automatically modulate its temperature by opening windows, tuning electrochromatic glass to change its thermal conductivity during the day. At night, we plugged into the grid where we purchased wind energy from Pepco. And I will close with this video to say that we have turned this moonshot into an Earthshot, and we are very hopeful that this Earthshot will inspire hundreds and even thousands of other companies around the world to build their buildings as zero carbon footprint buildings, because this building has shown and proven that it could be done even in a northeast climate like Silver Spring, Maryland. just really beautiful. I don't know if it's an eighth one. Thank you. So to wrap up with just, what lessons we've learned in turning moonshots into earthshots, I think a lot of it comes down to Voltaire being quite right when he said that the best is the enemy of the good. You saw over and over in my explanations, we tried to do something best. When we saw we wouldn't get that done within a decade time frame, we segued to do something good, and then to continue working on it. My co-founder and partner here, Paul Manns, always gives us the mantra, approve and then improve. So we follow that mantra. Another way to phrase it is we trade technological purity for economic practicality. The reason is time is very expensive. Einstein is said to have called compounding the eighth wonder of the world. And it works in reverse too, just like you go 1, 2, 4, 8, becomes big numbers very quickly. That applies also to the time value of money or time value of anything. So something that's not going to be ready for 30 years is just not going to be perceived as being very valuable today. And that's why it's better to work on things that are in 10-year kind of time frames. And my own personal mantra is that when you start walking, the best path will appear. For all of these different earthshots, I was not really sure of the way from A to Z, but as I began walking from A to B, the rest of the alphabet appeared. Thanks so much for your attention today. Thank you. Sure.
I would say a breathtaking talk. We have time for just a couple of questions. It is getting late. Does anyone have questions they'd like to ask? Martine? Please, right here in the middle. And I think we have microphones set up, so unfortunately we can't take everyone's questions because it's getting quite late, but maybe just a couple.
Hey, my name is Omer. It was a really awesome talk. I can't believe someone can fit this many amazing achievements into one lifetime.
Oh, wow, thank you. Thank you
as
very
you can,
much. Thank you. Thank you so much.
I think about that a lot, the idea of making the most value of your time. As you can tell, I look pretty young. I'm fairly young, just starting my career and trying to, I guess, change the world for the good, kind of like you are. If you had some advice for, someone who's my age who doesn't have the same platform that maybe you do, what advice would you give that person, and what lessons can I learn from this kind of story?
Omar, thank you very much for your comments, and I'm humbled by your praise, and you look like great. I think the best advice I could share was the company's mantra that was graciously shared during the introduction, which is to identify the corridors of indifference and run like hell down them. So find areas where other people are not working. And it sounds a little bit kind of prosaic, but be the big fish in a small pond rather than a small fish in a big pond. And if you choose your pond strategically, it will grow as you grow.
Thank you.
Sure.
Could you talk a little bit about what you're doing with pig things and other animals?
Yes. We are modifying the pig genome so that we can grow organs within pigs that will be compatible when they're transplanted into people. And there are basically several different things to consider in this. First, you have to have an organ which is not going to present too many targets to the human immune system that it will engage in what's called a hyperacute rejection or even an acute rejection of the transplanted organ. And we found that by knocking out several genes in the pig and knocking in several human genes that regulate complement, which is part of the immune system in particular, we are able to have these organs when they've been transplanted into baboon models, transcend hyperacute and acute rejection. It's also necessary for these organs to avoid causing coagulation and hematological problems in the human recipient. So we've addressed additional genes in the pig, such as von Willebrand factor, replacing porcine von Willebrand factor with human von Willebrand factor. And finally, there are a number of different genes that are concerned with general inflammatory reactions. And we've tried to replace genes in the pig genome that give rise to undue inflammation when they're transplanted into people with human analogs of those genes. It's easier said than done, because but that's true. But in addition to that, the genome is just not like a Scrabble board or something that you could just replace things anywhere you want. Human biology is more complex, really, than we are even close to beginning to understand. But we have done a pretty good job of routinely getting our xeno kidneys, that would be the poor genetically modified pig kidneys, to survive in baboons for more than a half year. Hearts in a heterotopic position, meaning not carrying the full burden of pumping the blood, for multiple years, and even in the orthotopic position inside the chest, pumping blood for over a half year. So we're making a lot of progress in this domain. Also, there's a possibility to transplant along with the pig organ some antigenic matter from the pig that would allow the recipient's immune system to be chimerized, meaning to become a blend of their native immune system and the pig's immune system in a small sort of way. For example, we will transplant sometimes the thymus of the pig along with the kidney, and that gives a chance to blend the recipient's immune system so that when they get the pig organ, it looks to the person like itself. For example, if somebody gets a bone marrow transplant from Mr. Smith, and then it has happened several times, later receives a kidney from Mr. Smith, that individual does not require any immune suppressants because their immune system has been chimerized together with that of Mr. Smith and accepts the kidney.
Any chance that it'll be done in 10 years?
Hi, thanks again. Very inspiring, energizing lecture. I'm curious to know, did you have any ideas or moonshot ideas that didn't work out?
I think of it as still working on them.
All right, thank you very much. Let's give you
Thank you. My pleasure. My pleasure. Thank you very much. Thank you.
Before she started. I think so.